Why It Sucks to Be Born as an American, Part 5, Healthcare Apartheid. Imagine waking up in the middle of the night with a sharp pain in your chest. Your heart is racing. You can barely breathe. You know something is terribly wrong. Now imagine that, in that moment of terror, the first thought that crosses your mind is not, "I need to get to a hospital." It's, "Can I afford this?" For tens of millions of Americans, that is not a hypothetical. It is a real lived calculus, one made in kitchens and living rooms and cramped apartments across every state in this country. The decision to seek medical care weighed not just against physical pain, but against the fear of debt, of bankruptcy, of losing everything. This is the story of American healthcare. One of the wealthiest nations on earth, a country that has mapped the human genome and pioneered treatments that have saved millions of lives around the world, and yet at home. It has built a system so complicated, so costly, and so unequal that the very people who need it most are often the ones least able to access it. We are going to explore how America arrived at this moment. Examine the structural failures that have turned medicine into a marketplace. And most importantly, look at the devastating human cost those failures have had on poor communities, communities of color, rural towns, and the working poor who fall through every crack in the system. To understand why American healthcare fails the poor, we must first understand how it was built, because the inequalities we see today are not accidents. They are features of a system designed, piece by piece, over more than a century of legislation, lobbying, and social compromise. In the early 20th century, the United States had no organized healthcare system at all. Medicine was rudimentary. Doctors were paid out of pocket. Hospitals were sparse and largely charitable institutions. The poor received care when they received it at all through the goodwill of physicians or the limited resources of public hospitals. As medicine advanced in the 1920s and 1930s, costs began to rise. And with those rising costs came a new question: how would ordinary Americans pay? Europe began answering that question with government-run insurance programs. Germany had led the way under Bismarck as far back as 1883. Britain established its National Health Service in 1948. Country after country concluded that healthcare was too important, too essential to human dignity and economic productivity to leave to the whims of the market. In the United States, a different path was chosen. Or, more precisely, the government path was blocked at nearly every turn. When Franklin D. Roosevelt crafted the New Deal in the 1930s, he initially wanted to include a national health insurance program. Advisors warned him that the American Medical Association, one of the most powerful lobbying groups in the country at the time, would fight it so ferociously that it could sink the entire New Deal. Roosevelt dropped the idea. Harry Truman tried again after World War II. He proposed a universal national health insurance plan in 1945 and again in 1949. The AMA spent millions of dollars, an astronomical sum at the time, denouncing his proposal as socialized medicine. They sent pamphlets to physicians' offices. They ran newspaper ads. They lobbied Congress relentlessly. Truman's plan died in committee. There was something else at work in these failures, too. Something more insidious. When Social Security was crafted in 1935, domestic workers and agricultural laborers were explicitly excluded from its protections. These were, not coincidentally, the professions dominated by Black Americans in the Jim Crow South. The same exclusions appeared, in various forms, in other New Deal programs. The architects of America's social safety net built racial exclusion into its very foundation, and healthcare would be no different. It was not until 1965, under Lyndon B. Johnson, and in the wake of the Civil Rights Movement, that the federal government established Medicare and Medicaid. Medicare provided insurance for Americans over 65. Medicaid provided coverage for the very poor. These programs were transformative, genuine lifelines for millions of Americans who had previously gone without. But they were not universal. They were carved-out categories. And between those categories, between the elderly and the indigent, fell tens of millions of working Americans, too poor to afford private insurance, too wealthy to qualify for Medicaid, and too young for Medicare. The foundation of American healthcare was built on a patchwork of compromises, exclusions, and half measures. And the people left out were, disproportionately, the poor, the black, the brown, and the working class. That foundation has never truly been repaired. And we are still living in the structure it built. To understand why healthcare is so catastrophically expensive in the United States, and why that expense falls so cruelly on the poor, we need to look at the machinery of the system itself. The United States spends more on healthcare per capita than any other developed nation. As of the most recent data, Americans spend over $12,000 per person per year on healthcare. That is nearly twice what Germany spends, nearly 3 times what the United Kingdom spends. And yet, on most major health outcomes, life expectancy, infant mortality, rates of chronic disease, survival of preventable conditions, the United States ranks near the bottom of wealthy nations. More money, worse outcomes. How is this possible? The answer lies in who profits and who pays. The American healthcare system is not one system. It is a tangle of private insurance companies, hospital systems, pharmaceutical corporations, medical device manufacturers, and billing intermediaries, each extracting profit at every node of the system. When a patient visits a hospital, they are not interacting with a public service. They are interacting with a market, and in that market, the incentives are not aligned with their healing. Consider the insurance industry. Private health insurers in America operate on a profit motive. Their fundamental interest is to collect premiums, the monthly fees you pay for coverage, and pay out as few claims as possible. Every denied claim, every rejected treatment, every administrative hurdle is, from the insurer's perspective, a cost saved. The complexity of the system, the prior authorizations, the network restrictions, the deductibles and copays, and out-of-pocket maximums is not accidental bureaucracy. It is, in many cases, deliberate friction designed to reduce the number of claims paid. For a poor family, this friction is devastating. A wealthy professional who is denied a claim can appeal, hire an advocate, or simply absorb the cost. A minimum wage worker with 3 children cannot. They forego the treatment. They ration the medication. They wait until the problem becomes a crisis, and then they go to the emergency room, which is the most expensive care in the system, and which they cannot pay for, which becomes medical debt, which destroys their credit, which traps them further in poverty. Now consider the hospital. In most countries, hospitals are either public institutions or heavily regulated. In the United States, approximately 58% of hospitals are nonprofit, but nonprofit is a tax status, not a behavioral description. Many nonprofit hospitals pay their executives millions of dollars, spend lavishly on facilities and marketing, and still receive enormous tax breaks meant to compensate for their charitable mission. Studies have found that many nonprofit hospitals provide less charity care than the value of their tax exemptions. For-profit hospitals, meanwhile, have a clear mandate: generate returns for shareholders. Decisions about which services to offer, which communities to serve, and how aggressively to pursue collections are made with an eye on the bottom line. Poor communities, which generate less profitable patients, are chronically underserved. Hospitals in wealthy suburbs thrive. Hospitals in poor urban and rural areas close. And then there are the drug companies. The United States is nearly alone among wealthy nations in allowing pharmaceutical companies to set their own prices for medications. The result is staggering. Americans pay, on average, 2 to 3 times more for prescription drugs than citizens of other developed countries. Insulin, a medication that has existed for over 100 years and is essential for the survival of millions of diabetics, costs on average 10 times more in the United States than in Canada. There are Americans who die because they cannot afford insulin. Not in the 19th century. Not in a developing country. In the United States of America, in the 21st century, people are rationing or going without a century-old medicine because they cannot pay what a corporation has decided it is worth. For poor communities, the drug pricing crisis is a daily reality. It is the grandmother who splits her blood pressure pills in half to make them last longer. It is the young man with asthma who skips doses because his inhaler cost $150. It is the cancer patient who chooses between chemotherapy and keeping the lights on. This is the machinery of American healthcare. a system that extracts maximum value at every point of contact from a population that has no real choice but to participate because the alternative is sickness and death. The story of American healthcare is not only a story of failure, it is also a story of people, communities, and institutions fighting back. And it is a story where the future has not yet been written. Community health centers, federally qualified health centers, are one of the least celebrated but most effective elements of the American healthcare system. They exist in medically underserved areas, both urban and rural, and provide primary care to patients regardless of their ability to pay. They are open to all: the uninsured, Medicaid patients, migrant workers, homeless individuals. They provide dental care, mental health services, and substance use treatment alongside primary care. Studies consistently show that they produce excellent health outcomes at lower cost than emergency room-centered care. There are now over 1,400 such health center organizations operating more than 14,000 service delivery sites across the country, and they serve over 30 million patients. They prove that it is possible to provide quality, affordable primary care to poor communities when we decide that is a priority. The Affordable Care Act, for all its compromises and limitations, was a genuine step forward. It extended Medicaid coverage to millions of previously uninsured adults. It allowed young adults to stay on their parents' insurance until 26. It eliminated lifetime caps on coverage and prevented insurers from denying coverage based on pre-existing conditions. Studies have found that the ACA reduced mortality among low-income adults, that people did not die who would otherwise have died because they gained access to coverage. Advocates for a single-payer system, where a single public insurer replaces the patchwork of private coverage point to the evidence from every other wealthy country. In Canada, in Germany, in France, in Japan, every resident has access to health care regardless of income or employment. Outcomes are better. Costs are lower. No one goes bankrupt paying for cancer treatment. The administrative complexity that consumes roughly a third of American healthcare spending is dramatically reduced. Whether the United States will move in that direction is a political question, not a medical one. The evidence of what works is not in dispute. At the community level, there are models of what solidarity can look like. Free clinics staffed by volunteer physicians. Community health workers who serve as bridges between underserved communities and the healthcare system. Trusted neighbors who can help people navigate appointments, understand diagnoses, access social services. Harm reduction programs that save lives by meeting people where they are. Doulas who provide culturally competent support to Black mothers and dramatically reduce maternal mortality rates. These are not solutions to systemic failure, but they are evidence of human decency operating within a broken system, and they point toward what a more just system might look like. We return at the end to where we began, to the person awake at midnight, chest tightening, wondering whether they can afford to save their own life. This is the most fundamental question a society can answer. When one of us is sick, what do we owe each other? America has, for most of its history, answered that question through avoidance, through compromise and half measures and systems designed by political and economic forces that profit from the status quo. Through a rhetoric of individual responsibility that obscures the structural forces that make some people sick and others well. Through a tolerance for inequality so profound that we have accepted, as normal, a reality in which your life expectancy depends on your zip code, your income, and the color of your skin. The suffering documented in this narration is not inevitable. It is not a law of nature. It is a consequence of choices, and choices can be remade. Other nations have made different choices. They have decided that healthcare is not a luxury or a commodity, but a right, that the measure of a civilization is how it treats its most vulnerable. That a society which allows its poorest members to suffer and die from preventable, treatable conditions is impoverishing itself morally, economically, and humanly. The road from where we are to where we could be is long, and it is contested. There are powerful forces that benefit from the current system. Change will require political will, sustained organizing, and a public willing to demand better. But the first step is to see clearly. To look without flinching at what the system is, and what it does, and who it harms. To know the names, even if we have not spoken them today, of the people who rationed their insulin, who who skipped the mammogram, who gave birth on the side of the road because the hospital was too far, who went bankrupt after a cancer diagnosis, who died in the waiting room. They are not statistics. They are people. They are our neighbors and our family members and our fellow citizens, and they deserve better. America has the knowledge, the wealth, and the capacity to build a healthcare system that serves everyone. The only question is whether it has the will. That answer, that choice, belongs to all of us. If you enjoyed this video, subscribe to stay informed, like to amplify the message, and turn on notifications.